right, welcome back, Bio 153 students. We are continuing with Chapter 20, which goes over the cardiovascular system. We've already gone through the first part that looks really more at the anatomy and blood flow, and now we're going to really focus in on the physiology in Part 2 here today. So, welcome! So, first we're going to take a look at this graph here, the action potential of the contractile cardiac muscle cells. So these cardiac cells, the contractile, make up 99% of the cells in the heart. And we take a look at this graph and the axes here. So here we have the y-axis on this side, which is represented by the membrane potential in millivolts. And the x-axis on the bottom of the graph here is represented in time, milliseconds. So looking at the time frame of how long the action potential goes on, again, membrane potential in millivolts is the charge. Right at the bottom of the graph down here, we are looking at what's known as the resting membrane potential, and that charge there is roughly about negative 90 millivolts. So that's referring to the effect that internally inside the cell it's very negative. But eventually this will change as you have some ions that may move from one adjacent cell to the other through gap junctions. Eventually this will lead us into stage 1 in the graph. So stage 1 in the graph here, this time frame is represented by depolarization. So number 1 here is referring to the depolarization and our lovely graph. Okay, so this is depolarization. So what's happening here is the effect depolarization that you have sodium channels that open. These are voltage gated channels, and this is going to lead to sodium that's found outside of the cell to come into the cardiac cell. You also will have some calcium channels that start to open up as well. You do have some calcium that's also found outside of the cardiac cell through calcium slow channels. So some calcium will enter. You do have some calcium that's also stored in the sarcoplasmic reticulum. The SR then, abbreviation for sarcoplasmic reticulum, will go ahead and release the calcium. So this is that whole idea of influx, referring to these ions come into the cardiac cell. Those are the big events that take place during depolarization. So we go from it being very negative internally in the cardiac cell to becoming eventually very positive. And you get to the top here, and this is roughly about positive 30 millivolts here. And this entire time frame right here on the graph is the depolarization. Okay, depolarization. So it's very positive inside the cell now. And the action potential is being fired across the cell. But this event is able to be prolonged because of stage 2, known as the plateau phase. The plateau phase. So on this graph, that is represented here, number 2. This represents the plateau phase. So number 2 on the graph here is represented as the plateau phase. So plateau phase. So that's this area right here, plateau phase. So you can see the curve is going down slightly, but it's a little flat there. It's not a huge sharp drop, but it does drop a little bit in charge. The main events that take place here during the plateau phase, the calcium channels remain open. You still have calcium flowing into the cardiac cell. You still have calcium released from the sarcoplasmic reticulum. You do have the sodium channels that close. So those voltage-gated channels I briefly mentioned, the channels close, no more sodium comes into the cardiac cell, but you do start to have some potassium channels that open up. So there are a few of these calcium channels that open up, and so you do have some of that potassium here that starts to move from the cell going outside of the cell. So the plateau phase, kind of a check and balance type of thing. You have calcium coming into the cardiac cell. You have potassium leaving the cardiac cell. And because of this situation, we're able to maintain the action potential for a longer period of time. Eventually, though, we make our way into stage 3 on the graph. So stage 3. And so this is represented by what's known as the repolarization. So repolarization. So we start with the cell being very positive, but then eventually it drops off to become very, very negative. So it's a big decline here. When we look at this portion of the graph. Big decline here during repolarization. So it becomes very negative once again in the cell. The reason because of that, you can see here, the calcium channels close. You no longer have any more calcium coming into the cell. Calcium that was bounded to troponin, okay, that regulatory protein, sliding filament theory concept, that calcium goes back to the SR. And you do have a lot of potassium that is leaving the cardiac cell too. All these voltage-gated channels for potassium are open, and you have a lot of potassium that is leaving the cell and going to the outside. So we end up being very negative again. And then, one final thing to consider here, we've gone through the events of repolarization already, which are right here. And we've gone through the plateau phase and depolarization. But we haven't mentioned yet the sodium-potassium pump. This pump is very important. It is a great example of active transport. So if you remember your transport processes from last semester, passive transport, active transport, this is a great example here of active transport, where you have materials, molecules, ions, things like that, that move from an area of low concentration to high concentration against the concentration gradient. And that's what the sodium-potassium pump will do. It's an active transport example. It's energized because of ATP. And it's going to be moving sodium-potassium. It's going to be moving these ions back to where they typically are found in high concentrations when we have our resting membrane potential, where the cardiac cell is at rest, and it's negative. So the ratio of movement of the sodium and the potassium, that ratio, maybe you remember it from 152, but that ratio is a 3-to-2 type of ratio. Okay? So it's a matter of 3 sodium ions are going to go back to the outside of the cell in comparison to the potassium ions. They need to go back into the cardiac cell. Okay? So you have 3 sodium ions. So 3 sodium ions. I guess we can use our little eraser here. There we go. So 3 sodium ions ultimately are going to leave the cell. The cell I'm talking about is the cardiac cell. And 2 potassium ions are ultimately going to move back to the cell. And I've kind of ran out of room here. But back to the cell. And we'll show you this illustration on the next slide. You might be wondering, well, Chris, what is this question about here? What is the purpose of a long absolute refractory period? Remember that we talked about this back on the first part of this chapter. The absolute refractory period is the time frame where the action potential is being fired. And the purpose of having a very long absolute refractory period, the time frame when the action potential is being fired, is in the heart, it allows for enough time for blood to be pumped through the heart so you have a heart contraction. And that's the purpose. There's a very short absolute refractory period in skeletal muscle with the action potential being fired across. So that's the purpose for having a long one here when you put the physiology into perspective. So there's a lot going on here. The big things you need to know off this graph, if I were to give you a graph like this, you need to be able to label these 3 main stages on the graph, right? So number 1 is referring to depolarization, which is pretty much this part of the graph. 2 is the plateau phase, so you need to be able to identify that. And number 3 is the repolarization on the graph. The graph here that we're really focused in on is this blue graph right here. This purple one here that goes up, all this is referring to surface tension development internally in the heart. But the parts on the graph you need to label, this blue graph is right here, 1, 2, 3. You need to label those 3 main stages on the graph. And you need to explain the events that happen at each stage on the graph, which is pretty much this information right here for depolarization, the plateau phase, the repolarization. And the sodium-potassium pump is a separate part after repolarization. You definitely need to make sure to understand that too. Okay? So we'll look at this a little bit more now, more down at the molecular level here on our next slide. All right, so let's review the action potential of the contractile cardiac muscle cells. Of course, like I've mentioned on the previous slide, these cells make up 99% of the cells in your heart. The other type of cell that we're going to look at very shortly are those pacemaker cells. I briefly mentioned those, but we have what are known as pacemaker cells. And they make up roughly 1% of the cell type in your heart. Okay? So the contractile cardiac muscle cells make up 99% of the cell type in your heart. Pacemaker cells make up 1% of the cell type in your heart. So let's take a look at this from a molecular perspective. Why not have some fun, eh? All right, so let's imagine that we have 2 adjacent cardiac cells. We have one here, and we have one here. And again, the cell type here we're looking at are the contractile cardiac muscle cells. So we'll do some erasing here. Leave some room here for us. All right. And at a state of rest, we're at a resting membrane potential. It's very negative inside the cell. So very negative inside the cell. It's very positive outside of the cardiac cell. So negative inside the cardiac cell, very positive outside of the cardiac cell. And then it's a matter of knowing our various ions, our various cations and anions. So at rest, resting membrane potential, you're going to have a high amount of potassium at rest in the cell. You're going to have a high amount, and we can fix this here. You're going to have a high amount of sodium outside of the cell. You will have some calcium that's found outside of the cardiac cell too. So here's our calcium. You will, of course, have some calcium that is stored in the SR, sarcoplasmic reticulum, but I wrote it off to the side. Of course, it would be here in the cell itself, but again, for purposes so things don't get too cluttered, I put it out here. Now, you may also be wondering, well, Chris, how is it so negative inside the cell? We mentioned, oh my gosh, right? It's, negative 90 millivolts, right? And we're going to look at positive things. Well, there's other things to consider, okay? Internally in the cell, you also have chloride. That makes it pretty negative. You also have, you can have protein anions. And we'll fix this here for you. All right. So you can have protein anions too that can make it negative as well. So that gives you an idea. All right, so negative in the cell, positive outside. Imagine that we had an action potential fired across this cell. Okay? And of course, we look at this action potential, this movement of electrical activity, excitement. And so we go from it being very negative inside here now in this cell to being very positive. Eventually, that's going to happen in this cell too. What I wrote right here is this is representing a gap junction. Remember I talked about those last time? Here we have a gap junction. So you can have some ion movement going through a gap junction. So maybe we did actually get a little bit of sodium inside the cell. This can actually lead to a triggering on the membrane, because on the membrane here, and I'm going to go ahead and erase a little bit here. Looks like I'm going to have to retrace that for us. You probably wonder, where did the outline go? So we can definitely work with that here. So imagine on the cell here, we have this voltage-gated channel right here. So I can just erase that. I guess for now we can do that. And imagine this being in the inactive state. You have the door to this channel here, this voltage-gated channel being closed. But with some cellular communication, this door can actually open up. And so that's what happens here eventually, is this door can open up, and this will allow then for the sodium to start to rush in. So you start to have a lot of sodium that comes in. Okay, so lots of sodium is rushing now inside our cardiac cell. Likewise, you also can have calcium that can come in. So we need to make some room here for putting our calcium, slow calcium channel in. Of course, it would be inactivated at first, but then it goes ahead and it actually opens up. So we'd have to erase that here. And there we have it. And there's our cell again here. So you have calcium rushing in too. So now you're starting to have the calcium rushing in from outside of the cell. And you might even have some calcium released from the SR. These are major events that take place during stage 1, which is depolarization. Okay? So depolarization. So on the graph then, this will be represented right here. So that is depolarization. Okay? So it becomes very positive now inside the cell. And now we have this action potential being fired across the cell. All right, stage 2. We now take a look at what's known as the plateau phase. So the plateau phase. So during the plateau phase here, and just a second here. Obviously, not perfect here. So we'll get this here for you. There we go. I thought something looked a little odd. All right, so now we're at the plateau phase. So this means that the action potential is going to be sustained along the cardiac cell for a period of time. At the beginning of the cycle, though, you're no longer going to have sodium coming in. Okay, so this voltage-gated channel for sodium closes. However, you continue to have your calcium coming into your cell. You continue to have calcium being released from the sarcoplasmic reticulum. But you do start to have some potassium that leaves the cardiac cell through voltage-gated channels. So we're going to need to go ahead and make some room here for that. And now we can kind of draw that here. And there we go. So imagine that this voltage-gated channel for potassium was closed, but now it's become activated. And so now that's going to open up. And now you have that potassium that's rushing outside of the cardiac cell. So now you have potassium out there. But just a little bit leaves. So it's, again, like a check and balance type of ordeal. You have calcium that's coming into the cardiac cell, potassium that's leaving the cardiac cell. And on our graph here, that's stage 2, is the plateau phase. We're now going to take a look at the last phase, which is going to be your repolarization. So repolarization. So that's right here on the graph, right? We've already looked at the depolarization 1. This right here is the plateau phase. Now we're taking a look at the repolarization. During repolarization, what happens? No more calcium enters into the cardiac cell. Calcium that was connected to troponin, that regulatory protein. We think of that sliding filament theory concept. Goes back to the SR. And you have lots of potassium that leaves. And the action potential is no longer being fired across the cell. Okay, so it's no longer the case. Any of these positives that I have written in here are really long gone. And so it's very negative inside here. But we haven't gone back to resting membrane conditions yet. We need to get all of this calcium that is outside of the cardiac cell, and we need to get this potassium back into the cardiac cell, and all of this excess sodium needs to go back outside of the cardiac cell. So we got to do something about the sodium and this potassium. Remember, sodium's Na+, potassium is K+. So that's going to be the work of, again, the sodium potassium pump. And so literally this pump would be right on the surface here of the membrane. So we could probably make some room on here for us. So imagine we put that pump right here. Now, the thing to think about is there's not like one voltage gated channel for sodium or potassium, or one slow calcium channel, or one sodium potassium pump. There's going to be many, many, many. But for making things simplistic, I'm just writing one here. So if you're wondering, well, I think there's more, Chris. Well, yeah, that's true. All right, so imagine here's the pump. And remember the ratio, it's going to be 3 to 2. So 3 ions for sodium that are going to move, and 2 potassium ions that are going to move. So we need to go ahead and take that sodium. All that sodium then will eventually move back outside of the cell, back to where it needs to be at rest. And then all of this potassium is going to eventually likewise make its way back into the cell. And so that's going to help to reestablish the resting membrane conditions, and hence we'll be back at -90 here. So when we do that, again, no more potassium outside, right? That's all gone. And all that sodium is going to be gone in here. And then ultimately, we're back at rest. So when we're back at rest, we're going to get back to where we were in the beginning here. So we erase some of this here. We erase some of this here, this here. And literally we get back to a resting condition here. So internally in the cell then, it's literally back to where we started, where we have our sodium in high concentration out here, outside of the cardiac cell. Calcium found outside here of the cardiac cell. Other calcium stored in the SR. Your high concentration of potassium inside the cardiac cell, and along with your chloride here inside the cell, and protein anions. Okay, so hopefully this helps with our understanding. It's very important for you to know this concept. So definitely make sure to study this. We move on now, And we're now going to take a look at what's known as the intrinsic conduction system of the heart. The intrinsic conduction system of the heart. So the intrinsic conduction system is referring to the electrical movement that's flowing down our non-contractile cells, also known as autorhythmic. Of course, another term for that is simply the pacemaker cells. Okay? The pacemaker cells. Remember, they make up only 1% of the cell type in your heart. And they're very unique because they don't depend on the nervous system for activation. So, back in the day, in the lab, and this was a lab I did back when I was a student. We don't do this anymore, but we did a lab where we had actual painted turtles, and they would be prepped in the laboratory room. They would be given an injection of barbiturates to the brain to make it brain dead, essentially, because they can't feel any pain. And the shell would be cut, so that way when you set up your painted turtle in the lab and you tie down the limbs of the turtle, you take the shell portion off and you could actually see the heart. And then literally you could connect electrodes to the heart, and you could actually get an ECG reading, an electrocardiogram reading, which was pretty sweet. And then you could have fun with the sheep heart, the heart from the painted turtle. And you could do some blockages. You could play around and maybe try to make a first-degree block or second-degree block. Eventually maybe cut off the vagus nerve. And then towards the end of the experiment then, you could actually remove the heart from the body. So that's what this picture's showing here. This is a picture here of the actual heart from a turtle, painted turtle, removed. And then you could actually put it into a little like Petri plate per se with Rayner solution, and you could look at that under the microscope. And what's really cool is removing the heart from the body of the organism, the turtle in this case, the heart would still beat. It was really cool. It would still beat. And again, this is because of those pacemaker cells that's possible. So it will continue to beat for a period of time. Really cool concept. So I don't know. Maybe we should bring the lab back. Maybe not. I don't know. But it was kind of cool back in the day. All right. Another graph. I know you guys love your graphs. So now we're going to take a look at the graph of the action potential of the autorhythmic cells of the heart. Autorhythmic, again, referring to pacemaker cells. So this graph looks a little different maybe from the action potential graph of the contractile cardiac muscle cells. Axes are the same though, right? We have our x-axis, time in milliseconds. We have our y-axis as membrane potential in millivolts. But you'll notice that the stages are either in a different spot or even a totally different name and concept. So on the graph, we start here. We look at number 1, the first stage known as the pacemaker potential. So that's located right here on the graph. Here's our stage 1, the pacemaker potential here. So we start here at -60, a little different than the other graph that was -90. And you have opening of sodium channels and closing of potassium channels. And this is considered a very slow depolarization stage and very, very unstable too. Eventually though, it's possible that on the graph here then, that the charge may make it to -40 millivolts. This is the time frame of threshold. And that's what this dashed line represents here. It's the threshold line. So once you get to that threshold line, you get past that, pretty much you're committed to an action potential being fired from one pacemaker cell to another. So we go up that, and now we've made it into stage 2 on the graph. This represents the depolarization. So during the depolarization phase, we start off being very negative, but eventually we do get slightly positive, not nearly as high like we saw with the other cells where it was positive 30. Here it's looking like potentially maybe +3, +4 on the graph here. So this is stage 2 depolarization. The big events here for that, the calcium channels open. So you have a lot of calcium coming into the cell and hence action potential being fired. This is a very short-lived event, as you can see here on the graph. There isn't really a plateau phase. So it's very short-lived. And then we get into stage 3 on the graph. And stage 3 here is the repolarization. So repolarization, here the calcium channels close. No more calcium comes in. Potassium channels all open up. A lot of potassium then will leave. And it becomes, once again, very negative inside the cell. And then eventually we start this whole cycle over again. Here we have that pacemaker potential. Same idea right over here. So, okay. So again, the important things to know off this graph, definitely make sure to know the 3 main stages on the graph if you had to label them for me. And also important to know the main events happening at each stage on the graph. What are the main events for the pacemaker potential? For depolarization, for repolarization. So extremely important to definitely review that and to know that. We continue now by looking at the various steps of the intrinsic conduction system. So we'll go ahead and we'll take a look at that here next. So the intrinsic conduction system. It all starts with number 1, which is the sinoatrial node, or the SA node. This is considered to be the pacemaker. And this will generate, ultimately, your heart rate. On average, for most people, it's around 75 beats per minute. So this is the heart's pacemaker. And on the picture here, represented right here, the SA node right here. So that's found up in the right atrium. Electrical activity then will be transferred through this intrinsic conduction system to, number 2, the atrial ventricular node, or the AV node. There is a slight delay in the impulse here, and the importance for that is to allow the atria, so referring to the right atrium, left atrium, to complete their contraction before the ventricles will go ahead and contract. So on that little picture here, here we have the movement here of the electrical activity to the atrioventricular node right here. So that's kind of right up against the tricuspid valve. Number 3, with the intrinsic conduction system, we have the atrioventricular bundle, or sometimes abbreviated AV bundle, or also known as the bundle of His. And this is really the only electrical connection between the atria and the ventricles. So it's very important that this structure doesn't get damaged, obviously, or a blockage. So on here, that would be kind of right at the top here, the bundle of His, kind of almost at the top of what's known as the interventricular septum, which is the wall that separates the right ventricle from the left ventricle. We continue on by looking at the intrinsic conduction system here. So a couple other structures. We've already gone through the start of the sinoatrial node, and eventually electrical activity transferred to the atrioventricular node, to the bundle of His. And now it's a matter of understanding, number 4, the bundle branches. So there's a right and a left for the bundle branches, and they carry impulses ultimately towards the apex of the heart. These bundle branches run through the interventricular septum wall. So on this image, it would be right here and right here, the bundle branches. So ultimately going towards the apex of the heart would be over here. And then the last structure here for the intrinsic conduction system is the Purkinje fibers. And they're important for transporting the electrical impulse ultimately to the apex and the ventricular walls. So we take a look at that here, and the Purkinje fibers would be right here. So Purkinje fibers, and ultimately then we have that heart contraction. So extremely important to know the different parts of the intrinsic conduction system. This is just an overview again of the various parts of the intrinsic conduction system. So we'll go through this just one more time. This entire process starts with the pacemaker, the sinoatrial node, located again up in the right atrium. You then have electrical impulses transferring the signal to the atrioventricular node, which is right here. The signal then will make its way to the bundle of His, kind of at the top here of the interventricular septum wall. The electrical signal then will make its way down the bundle branches, which go through the myocardium of the interventricular septum. And then the electrical signal continues on through the Purkinje fibers, which are found in the myocardium of the actual ventricles, and hence a heart contraction will occur. So that's the normal process of how the intrinsic conduction system occurs. But this is not always the case for everybody. Some people have defects in their intrinsic conduction system. So perhaps maybe they have a defective SA node, or perhaps they have a defective AV node. So if someone has a defective SA node, it's very possible that they may have what's known as an etopic focus. And this term etopic focus is referring to that an abnormal pacemaker may ultimately take over in that heart. Or perhaps maybe the AV node temporarily decides to become the SA node. This type of example here can easily be known as an irregular heartbeat, or known as an arrhythmia. And if the AV node does take over, the individual may have junctional rhythm. Some examples of how some people may have an arrhythmia short term. It could be the cause of taking lots of caffeine. Maybe somebody's drinking a lot of coffee or Mountain Dew or Red Bull or whatever it might be, and their heart rate is significantly higher perhaps in this situation. Definitely people who drink coffee more on a regular basis in the morning, their body's kind of immune to that. But if it's somebody that doesn't drink caffeine on a regular basis, they may experience that arrhythmia. They may very well be taking Monster drinks too. Maybe you've seen those before at the gas station. And these Monster drinks definitely, if you drink too many, I mean, it could lead to significant elevated heart rate. Maybe it might do damage to the heart itself. We also then look at nicotine. Smoking cigarettes, like we see over in this picture here, the nicotine definitely can lead to an arrhythmia. So excessive smoking, obviously dangerous. And then we take a look down here, number 2, at the defective AV node. So this is where you'd have either a partial or perhaps a total heart block. Obviously, this can be very dangerous if you're not getting a whole lot of impulses down to the ventricles. We now take a look at how we have changes in the heart rate short term. And if we go up to the brain stem, there are two major centers we find there in the brain stem. We have the cardio-inhibitory center and the cardio-excelatory center. So how about first we'll look at the cardio-excelatory center. So the cardio-excelatory center, again, originates up in the brainstem, in the medulla oblongata. And imagine a situation where the heart rate can increase. And we think of this term, cardio referring to heart here, of course, and excelatory referring to, the increase occurring. So heart rate here, HR, is the idea that this is increasing short term. So there's a lot of examples how this can take place here. I have here driving on ice. I'm always scared driving on, winter time. You're on the snow, the ice, and you hit black ice, and your car slides, and you almost collide with another car. Boy, you can really feel that adrenaline rush. And whoa, your heart's just beating out of your body, So again, the cardio-excelatory center can send signals right here, signals that eventually go down these sympathetic cardiac nerves to the heart that can increase the heart rate short term and even force of contraction. The complete opposite of this now is taking a look at the cardio-inhibitory center. And this center is all about changing your heart rate by making your heart rate decrease short term. So you think of different things in your life that might relax you. Maybe it's listening to some music that relaxes you. Maybe it's a television show that relaxes you. So messages can leave the cardio-inhibitory center found up in the medulla oblongata and will go down a cranial nerve known as the vagus nerve. And the vagus nerve, the goal here is to decrease heart rate short term. So that's what we're imagining here. And ultimately then, heart rate will go down. Okay, so cardio-excelatory center, we think of that center in response to heart rate increasing, acceleration, driving fast, okay? Cardio-inhibitory center, we think of something being inhibited. If that's the case, it's usually a decrease, relaxation, so heart rate going down. Cardio-excelatory center, heart rate goes up. Cardio-inhibitory center, heart rate goes down. This is all short-term effect that takes place. So definitely very important to know this for sure. We're now going to take a look at a very important concept, very important graph. I know we've looked at two graphs already, but hey, why not look at a third graph? And that's looking at the electrocardiogram. So the electrocardiogram. So sometimes abbreviated as the ECG, sometimes known as the EKG. And this is a graphic recording of the electrical activity of the heart. So maybe you've seen this before. Maybe you already work in the hospital and you see the electrocardiogram in patients' rooms. Maybe you don't work in the hospital, but you've definitely been there to visit loved ones where perhaps they're connected to this machine because maybe they have heart disease or everything's being monitored to figure out what type of disease they may have. And what you'll find is that there's actually 12 leads that typically are utilized in a clinical setting in the hospital. And all of these different leads ultimately help to detect if there is any type of abnormal activity with the heart and look at different angles of the heart. And these various leads are placed in different parts of the body, like upper chest and arms and lower abdominal area, upper thighs, etc. So we look at the basics here. And there's three main waves that we look at when we look at an ECG tracing. So the first wave we're going to look at today is looking at what's known as the P wave. So this is the P wave right here. Okay? And the P wave, this first wave, this represents where you have atrial depolarization occurring. Atrial depolarization. And this is referring to simply that the atria are contracting. The P wave signals that. That's a representation of that. Okay? So your right atrium and your left atrium are contracting. Next, we take a look at the QRS complex. This is made up of the Q wave, R wave, S wave. And when we look at this entire complex right here, this is representing where we have ventricular depolarization occurring. Ventricular depolarization, referring to this is where the ventricles are going to be contracting. So right ventricle, left ventricle contracting. And then finally, the last wave here to be familiar with is the T wave. So represented right here. And the T wave is the time frame where we have the ventricular repolarization occurring, where your ventricles are relaxing. Your right ventricle, left ventricle. The one thing though, however, that you can't see on the electrocardiogram is the time frame of the atrial repolarization. And that's because you can't see it on the graph because it's blocked by the QRS complex. So you're not able to see it, it's blocked. And this is where the atria would be going through their relaxing. So ultimately, when you're looking at this, this is one heartbeat right here. Okay? So very important. This is the basics right here. So very important to make sure to know this. This is critical information to know. Okay, so here is some graphing paper looking at the electrocardiogram. And this just gives you an idea, if you've never seen it before, what it might look like. So here we have Roman numerals 1, 2, 3. So these are some of the different leads. So this is lead 1, this would be lead 2. Here we have lead 3. And you're able to also detect the different waves on the electrocardiogram recording. Here we have a patient right here that has the various leads placed on his body. You can see here the upper chest, along the sides of the abdominal area, upper arms. So that gives you a rough idea of what that might look like. But you'll have a lot of opportunities to see these things in nursing school. All right, so we've so far today discussed what the normal electrocardiogram would look like, which would be right here, letter A. This is representing the normal sinus rhythm. So everything's normal in this electrocardiogram recording. You have your P wave, you have your QRS complex, you have your T wave, and etc. But the other three here would be abnormal ECG tracings. And these are just three examples I'm showing you. You'll definitely see more different types of heart defects, etc., diseases in lab. The first one here, this is known as junctional rhythm. You can identify that the SA node is non-functional and P waves are absent. So that's what we're seeing here on the graph. No P wave. we have a QRS complex, a T wave, no P wave. So no P wave, no P wave, right? No P wave, no P wave. Letter C down here. Here we're looking at a second degree heart block. So what we find here with someone with second degree, we're definitely having difficulty getting the signal from the atria down to the ventricles here. And you end up with a ratio, it's a 2-to-1 ratio. And this is a ratio of P waves to QRS waves. So 2 P waves to 1 QRS wave. And we can see that here. Here we have 2 P waves. So a P wave, right? We have 2 P waves here. And then you have your QRX complex here. So here's your complex, QRS complex. And then you got your T wave. And then once again, 2 P waves, 1 QRX complex. That's the idea of the second degree heart block. All right, and then letter D, we have the ventricular fibrillation. Definitely, if you see this, this is definitely someone that's having possibly an acute heart attack. And again, they may be dead within a matter of seconds, perhaps. They might be flatlining soon. So this is definitely a catastrophic event here. You can't really identify really any of the waves here. Definitely not a good situation to be in at all. So that's the idea of the ventricular fibrillation. Pretty much the heart is becoming useless as a pump now. Okay, so these are just a couple to identify and to be aware of. All right, we're now going to take a look more at understanding of atrial fibrillation and what really is fibrillation. So the term fibrillation is referring to rapid irregular contractions that potentially could make the heart useless for pumping out blood. So atrial fibrillation, or sometimes abbreviated as AFib, is looking at the control of heart rhythm taken away from the SA node. And the SA node is found up in the right atrium of the heart. Its goal is to go ahead and try to get signals down to that AV node. And so because of there being an issue with the electrical activity not properly getting to the AV node, a lot of these individuals potentially may have high blood pressure, heart rate being high. Obviously, it's more difficult to get blood pumped out, so they may feel weak or something like that. So a lot of these individuals definitely need to be on medication. That's important. There's an increased chance with atrial fibrillation to get a stroke. So a lot of patients will be on blood thinners who have AFib. So maybe they're taking their aspirin, maybe they're taking warfarin as a preventative measure. Maybe they're off on some of their ion amounts, potassium maybe they're taking. So AFib can be controlled. Most people can live a fairly normal life. Definitely they can't do anything excessively stressful exercise-wise, but they can live fairly normal lives for a period of time. Of course, this can be a risk factor for developing congestive heart failure when you get older. And this image here is looking at a normal heart versus the ventricular fibrillation. We briefly went over that when we looked at our electrocardiogram pictures. So ventricular fibrillation is definitely more serious than AFib. And ultimately, someone gets into this because they go into cardiac arrest. Maybe it is because of an acute heart attack that someone sustains. And you get into cardiac arrest. The ventricles start to quiver, and you're not getting any blood that's going out of the heart. And again, it could be an acute heart attack someone's experiencing, and it's definitely catastrophic. And you look at the EKG readings, ECG readings, you really can't identify the waves at all. This is kind of a generic graph here when looking at ventricular fibrillation, but the big things that we can get off of this graph ultimately is the fact that, again, you can't identify the waves. They're really all irregular, really, when looking at ventricular fibrillation. And look at the heart rate here. Look at the heart rate of this person. 300 to 600 beats per minute for this brief period of time. And ultimately, that's real high. Blood pressure is real high, ultimately. Very brief time frame. Ultimately, the person will lead to death. P wave absent here, okay? Take this into consideration, this heart rate, where someone with an average heart rate is 75 beats per minute. All right, so we have a couple slides here to go ahead and review. So how about we'll go through these? So number 3 for review. So based on the ECG reading, the arrow is pointing to the blank, and it represents blank. So based off of our understanding of the electrocardiogram, what would be the correct answer here? What would be the correct answer here? And the correct answer, which I would go for sure, I'd probably go with choice letter B. The arrow is pointing to the T wave, which represents the ventricular repolarization, right? Because right here, this is the T wave, this is the P wave, and of course, this is the Q, R, S complex. Okay, our next review slide, number 4. Based on the above ECG tracing, please identify the heart condition. So, what heart condition are we looking at here? What heart condition are we looking at here? And the correct answer, what I would go with, based off of these choices, I would probably go with choice letter D, which is the ventricular fibrillation. Again, catastrophic event, someone's experiencing an acute heart attack. Number 5 for review. Looking now at the action potential of the contractile cardiac muscle cell graph here. So, number 5, sodium ions are rapidly entering the cardiac cell during which stage? What stage was that we mentioned? What stage would that be? And the correct answer, I would go with choice letter A, depolarization. That would be right here. This is referring to depolarization. Up here, this would be the plateau phase. And right here, C, repolarization. Number 6 for review. Again, looking at the action potential graph here for the contractile cardiac muscle cells. So, during repolarization, which of these would be true? Which of these statements would be true? Okay, and the correct answer here would be choice letter D. D is the correct answer. So all potassium channels are open, all those voltage-gated channels are open, and the potassium moves out of the cardiac cell. That's the correct answer. And of course, repolarization, right, would be right here. So C is not entirely correct because the potassium is not moving to the cardiac cell, it's moving out. The potassium comes in through the sodium-potassium pump, but here we're just talking about repolarization. And we have number 7 for review. This is looking at the action potential of the pacemaker cells. So here we're looking at that graph. So looking at this, the opening of the sodium channels and the closing of the potassium channels occurs during which stage? Which stage would this be? Okay, and the correct answer would be choice letter A. And where is this on the graph? It would be right here. This spot, right here. Likewise, right here. So, pacemaker potential, letter A, is correct here. We move forward now, and we're going to take a look at heart sounds. So, I'm sure you go to the doctor, and your family doctor comes in, and they check your breathing, and they have their stethoscope, and they're like, all right, Chris, take a deep breath, and they're listening to the heart sounds. Is the heart doing okay? So there are 2 major heart sounds that the physician is listening to. And that's going to be your first heart sound, the S1, and the second heart sound, the S2. And the S is just referring to sound. The 1, the first heart sound. So that first sound that the physician hears with the stethoscope, S1, first heart sound, is referring to that the AV valves are closing. So the closure of your tricuspid valve and the closure of your bicuspid valve. The second heart sound, S2, is referring to the closure of the semilunar valves. So closure of the pulmonary semilunar valve and closure of the aortic semilunar valve. Now, some people might even have what are known as heart murmurs, and these are going to be abnormal heart sounds, where maybe the valve is not properly opening and closing. Maybe there's some obstruction. Some people may even have a third or fourth heart sound, which would be abnormal in an adult. So, very important to know your first heart sound and your second heart sound. This leads us eventually now to taking a look at the cardiac cycle. So the cardiac cycle is referring to all the events associated with blood flow through the heart in one complete heartbeat. So this is taking into effect everything we've really learned so far. Heart sounds, blood flow, everything so far. We'll see this on the graph coming up. 2 very important terms that are critical to be aware of is systole and diastole. Systole is referring to the contraction of either the atria or ventricles. The term diastole refers to relaxation. So relaxation of the atria and ventricles. A couple of really important points to think about is blood flow moves through the heart. Ultimately, it's controlled by pressure changes. So maybe an increase in pressure or decrease in pressure in a heart chamber. And blood flow ultimately will move down a pressure gradient to any opening that is available. So let's go ahead and take a look at the stages of the cardiac cycle here next. So, the cardiac cycle phase 1. The first overall phase of the cardiac cycle is called ventricular filling. Ventricular filling. And this is occurring from the time frame of the mid to late diastole. So some of the key things that are happening during ventricular filling, of course, the AV valves are open, and this allows for the blood to go ahead and move into the ventricles. 80% of blood passively will flow into your ventricles. So we can kind of see this a little bit on the graph here. This graph here is showing the effects on the left side of the heart. So here's ventricular volume here. Okay. So of course, a lot of blood is going ahead and moving into the ventricles here. We also look at pressure here. So this is looking at pressure in various heart chambers that's taking effect here. Heart sounds here as well. And then we get into eventually the blood getting into the ventricles. Eventually we get to a point where the atria contract. So atrial contraction, looking at the systole. This will deliver the 20% of remaining blood, is when the atria actually contract. So then you get all the blood into the ventricles now. So on this graph here is the atrial systole. So there is a slight increase in pressure associated here. And the P wave, of course, representing that the atria contracted. One thing to consider here too is when we look at this image, this is just a graph looking at the left side of the heart. So one thing to think about with the cardiac cycle is the cardiac cycle the same on the right side of the heart versus the left side of the heart? Would it be the same? Would it be different? What do you guys think? What do you think? I hope as you're thinking about this question and answering this question that the cycle would be different. The right side of the heart is under less pressure. Blood's only going to the lungs. So a lot more, the pressure is significantly lower. This image is illustrating the right side of the heart, so pressure will be significantly higher because the blood has to go throughout the body. So it wouldn't be exactly the same. It would be a little different. So far here, phase 1 is looking at ventricular filling. So we can see that down here, ventricular filling. Ultimately, right here is the name of the phase 1, and with that, the atria contract. So we leave off now with the blood being in the ventricles. Phase 2 of the cardiac cycle we take a look at next. So, cardiac cycle phase 2. We take a look at what's known as ventricular systole. Ventricular systole. So, now it's the idea that the atria are relaxing and eventually the ventricles will contract. And there'll be an increase in ventricular pressure, which does close off the AV valves. So, ventricular systole is broken down into two major subcategories. First, we have the isovolumetric contraction phase. And this is where we have all valves are closed and blood volume is constant. And this is really just a really short period of time where that's the case. Very short period of time. Because eventually, we'll see here, but pressure will start to increase in the left ventricle here. And valves are all closed here, so here is S1, AV valves closed, QRS complex reflecting the effect that the ventricles contract. So pressure is going ahead, building. And then that gets us into looking at the second subcategory, the ventricular ejection phase. So with this phase here, again, ventricular pressure increases significantly, which will force open the semilunar valves. And so those are going to open up, ultimately because the pressure was building so much. And with the semilunar valves opening, eventually then you're going to have that blood supply in the ventricles leaving and going into your pulmonary trunk and ultimately going into your aorta. So this gets us into phase 3 of the cardiac cycle, which we're taking a look at here next. So cardiac cycle phase 3. And this is known as the early diastole. So the isovolumetric relaxation. Again, the blood is flowing into the pulmonary trunk and the aorta. This is reflected again at ventricular volume going down significantly here. And this is also a time frame where the ventricles are relaxing. And they're relaxing, the blood flow again is up in the pulmonary trunk and aorta. And pressure is going down significantly in the left ventricle. And so this is represented, ventricles relaxing with the T wave. So in order to close the semilunar valves, the pulmonary semilunar valve and aortic semilunar valve, there is a backflow of blood in the aorta and pulmonary trunk. And this backflow of blood here, the blood is flowing backwards towards these semilunar valves and will actually close them off. Now, a part of what assists with that process, at least with the aorta, is the dicrotic notch. This is a brief rise in aortic pressure. And this is represented right here. So this kind of helps ultimately with the closure of the semilunar valves, represented by the second heart sound here. And then ultimately now, those semilunar valves are closed, and the blood will continue on, either to the lungs or throughout the body. And ultimately, we have gone through an entire heartbeat here, looking at the cardiac cycle. So, pretty exciting. Definitely make sure to review the overall phases of the cardiac cycle. Very important to review this for sure. We now take a look at cardiac output. And cardiac output, CO, here's the equation. So cardiac output, CO, is going to equal heart rate times stroke volume. So cardiac output equals heart rate times stroke volume. Cardiac output, CO, is going to equal the volume of blood pumped by each ventricle in a minute. So the volume of blood pumped by each ventricle in a minute is cardiac output. Heart rate is the number of beats per minute, and stroke volume, SV, is the volume of blood pumped out by one ventricle with each beat. So heart rate, this is something that you can get by taking a pulse. You can get this if you have a heart rate meter, if you're exercising. The stroke volume, the volume of blood pumped out by one ventricle with a beat. This is something that you can definitely get if you're getting an echogram done from a cardiologist. So there are different ways to get that, these different variables here. So let's look at differences in cardiac output between someone that lives a sedentary lifestyle and someone that lives more of an athletic lifestyle with lots and lots of exercise. All right, so first we'll look at the athlete, someone who's an athlete here, and they're doing a lot of cardio. We look at normal resting values of cardiac output, and a normal resting value typically is about 5.25 liters per minute for average cardiac output. Somebody who's a big athlete, their max CO might reach 35 liters per minute in trained athletes, 7 times the resting value. And that's definitely the case for people that do a lot of running. And maybe they run marathons all the time. A big one in definitely our country is the Boston Marathon on Patriots Day in Boston, Massachusetts. That's a big one. You have to actually get a actual time to even qualify, and the best endurance runners in the world are there. So somebody who's doing a lot of cardio is really getting that cardiac output up high. And it doesn't necessarily have to be running. The individual could be big into swimming, which is endurance, or biking, or cross-country skiing. All of those things are big endurance activities. And what you'll find with these individuals is that they have a very low resting heart rate. Maybe they have a heart rate of 50 beats per minute or something like that. And they have a very high stroke volume. You may ask yourselves, why do the athletes have a very low resting heart rate? How is that even possible to maintain? Well, it definitely helps with the high stroke volume, but it's also because of the overall strengthening of the heart muscle. You're getting more blood coming up, more venous return, so stroke volume goes up. So venous return is referring to just more blood coming through the heart, and you're ultimately strengthening the heart muscle. So a stronger heart muscle, toning the heart muscle, the cardiac muscle, that stroke volume can be up and you can maintain the low resting heart rate. We now take a look at cardiac output in someone that lives more of a sedentary lifestyle. So here's someone who's relaxing on the couch, loves TV, doesn't exercise at all, eats whatever, and their cardiac output will be slightly different. We look at normal resting values. A normal resting value is 5.25 liters per minute. And a max CO here for them is just 4 to 5 times the resting CO, the resting cardiac output. In the case with these non-athletic people that live a sedentary lifestyle, they will have a high resting heart rate and a low stroke volume. And that makes sense. If you're not exercising, you're not getting a lot more blood going through the heart muscle, the heart's not as strong or toned, and they have a high resting heart rate. Maybe they have a resting heart rate value of 100 beats per minute, maybe, for overall heart rate. And their stroke volume will be very low. They're not getting as much blood moving through. Definitely the goal is for us to be more of the athlete, per se. That's the goal, to be strong and keep our fitness high. We now take a look at the regulation of stroke volume. This might be one term we're not as familiar with, stroke volume. So we look at stroke volume, and ultimately it's looking at the end diastolic volume, EDV, minus the end systolic volume. So 3 main factors affect stroke volume. One is the idea of what's known as preload, and this is referring to the degree to which cardiac muscle cells are stretched before they contract. A law that really goes through this understanding is what's known as the Frank-Starling law of the heart, which is referring to the effect if you were to do cardio activity, maybe running or doing your spinning class or whatever it might be, that increased venous return, so increased blood coming into the heart from the vena cavas, can lead to an increase in the stretching of the ventricles. Another important factor affecting stroke volume is the concept of contractility. Contractility. And this is referring to contractile strength at a given muscle length. And this can definitely vary with increase in calcium or hormones like epinephrine or norepinephrine when we think of rushes of adrenaline. And then number 3 for a factor is the idea of afterload, referring to pressure that must be overcome for ventricles to eject the blood. This image here ultimately is looking at factors involved with regulation of cardiac output. So again, a lot of these are probably no-brainers. Cardiac output ultimately can go up because of cardio exercise, endurance-related exercise. In turn, this leads to increase in stroke volume, excess calcium ions, epinephrine, things like that. Here's that idea of increased venous return. And then, of course, increased heart rate, too, can lead to this increase in cardiac output. So, again, the idea of exercise, but even differences sometimes in gender, age, body temperature can play a role here, increase in sympathetic activity. So, the big thing to be aware of is when you're exercising, when it comes to cardiac output here, cardiac output equals the heart rate times the stroke volume. So when you're exercising, cardiac output goes up. And it goes up, of course, because your heart rate increases, right? And also because stroke volume increases too. Because when you're exercising, more blood flow is going through, okay? And the heart's getting strong. So both stroke volume and heart rate will increase when you exercise. And that's definitely important to be aware of. All right, next slide here. So we've been looking at cardiac output and heart rate, stroke volume. And we've been talking about the idea that heart rate, the normal resting heart rate, is approximately around like 70, 75 beats per minute. But now we're going to look at two abnormalities when it comes to heart rate. And these two new terms here to be aware of are tachycardia and bradycardia. So tachycardia, this term refers to a heart rate faster than 100 beats per minute. And so there's many different causes for this. Elevated body temperature, most definitely. Stress in someone's life. Certain drugs, heart disease can all lead to that faster heart rate. Now, all of us have actually experienced tachycardia if you're exercising. Your blood pressure goes up when you exercise. So a short-term cause from exercise, well, that's normal. But if it's more of a serious matter, if it's persistent. And so if it's persistent, then we're talking about possibly promoting fibrillation, developing heart disease, things like that. Bradycardia is referring to a heart rate slower than 60 beats per minute. And this could be caused based off of low body temperature, certain drugs. It could be activation of the parasympathetic nervous system. So athletes, they actually, because of their endurance training, from biking or swimming or whatever it may be, they're able to maintain, again, that low resting heart rate. So they have the bradycardia, and they can maintain it because of their high stroke volume. Of course, some people have it, and this can lead to possibly inadequate blood circulation. And this is the case with poorly conditioned people. So very important to be aware of these two terms here, tachycardia and bradycardia. This leads us now to looking at congestive heart failure, CHF. So congestive heart failure is a progressive condition. So someone can live with this for a very long period of time. Someone could live with this for 10 years, 15 years. And there are many possible causes that can lead to someone having congestive heart failure. One being coronary atherosclerosis. So the clogging of coronary vessels, referring to your coronary arteries, right and left coronary arteries. Maybe there's buildup of plaque. So that can definitely lead to some stress to the heart. Someone that has persistent high blood pressure, hypertension. So that can be a big risk factor for CHF. Someone who experiences multiple heart attacks. The heart's getting weaker and weaker every single time, and this can lead right into congestive heart failure. Another possibility is number 4, what's known as the dilated cardiomyopathy, DCM. And this is when the ventricles are stretching significantly and they're working so much that they become flabby and the actual myocardium can actually degrade. So these are all possible risk factors for developing CHF. Obviously, there's many others too. Some of these would be things such as AFib. So AFib could be one, atrial fibrillation. heart murmur. Congestive heart failure can come on eventually from just not keeping up your exercise routine, sedentary lifestyle, smoking. So there's a lot of things that can lead to this. Alcoholism. There are many different forms of congestive heart failure, CHF. We're going to look at two basic ones here today, looking at the left side congestive heart failure, and then eventually looking at the right side congestive heart failure. So left side congestive heart failure is also known as pulmonary congestion. So pulmonary congestion, pulmonary, of course, referring here to the lungs when we look at pulmonary. So referring to the lungs. Left side of the heart failing. And someone that has left side congestive heart failure, they typically have a lot of pulmonary edema. So fluid buildup, that's occurring in the lung tissue. And this X-ray is kind of showing that here. Here is your right lung and your left lung. And here's a lot of that fluid right here. So edema buildup. And with that fluid buildup, if it's not treated, the patient will feel like suffocating. It's very difficult for gas exchange to occur, to get oxygen out eventually throughout the heart into the body to the tissues. And they'll have significant shortness of breath that can take place because you have all this fluid build up back up around the lungs, and very, very tough. So typically a patient like this, if they want to get rid of the fluid, typically they're going to probably take some type of diuretic, which will get rid of the fluid. So they'll probably be on that. And again, they're having the difficulty with breathing. Their oxygen saturation levels might be more in the 80s versus up in the upper 90s where it should be. Another type of congestive heart failure is looking at what's known as the right side congestive heart failure, which is also known as peripheral congestion. So right side of the heart fails. Here, definitely a difficulty of getting rid of the body of waste products and receiving of nutrients, oxygen to tissues. So here a lot of fluid buildup more in the extremities is taking place. So a lot of edema, fluid buildup in the extremities. So not the lungs in this case, but more of the feet, more of the ankles, more of the fingers. So we can kind of see that in the diagram image here. So again, here we have feet, ankles swelling up. You can have fingers as well. So that's more of what's happening here with right side failure. So again, treatment here, diuretics, like I've mentioned before, can be something that can be given to someone if they're suffering from left or right congestive heart failure. There's various drugs they can take because blood pressure typically is significantly higher in someone that has CHF. So for meds here, perhaps for blood pressure, maybe they're taking what's known as a beta blocker. Is just an example here. There are many more forms of medication, but a beta blocker is definitely one type of example that they could be taking. So beta blocker for blood pressure. If it's a matter of a diuretic, then they can take a medication. There's many different types out there, but Lasix is one they can take. So we'll work on fixing that here for you. So Lasix. So Lasix is one type of medication that they can take that can definitely help the patient out for sure. So these are some treatments, many others, of course. Usually people in CHF are, they may potentially be on other things too, blood thinners, taking potassium, so. Okay, now we're going to go back in time, and we're going to look now at the development of the heart, going back to when you were an embryo. So right here, the embryo. So way back in embryonic development, believe it or not, the heart actually starts to pump on day 22 of development. Day 22. And the early heart, pictured here, doesn't exactly look like the human heart, but slowly but surely it will happen. So we'll take a look at these structures and see what do they actually evolve into. So starting with the first structure, number 1, we look at what's known as the sinus venosus. The sinus venosus. And the sinus venosus receives all of the venous blood of the embryo. And eventually, this structure will evolve into the right atrium and the coronary sinus in the human heart. So that's number 1, the sinus venosus. Number 2, we have what's known as the atrium. So the early embryonic heart, all it has is an atrium. Eventually, this structure will evolve into the pectinate muscles. These are the ridges found in the atria, in the right atrium and left atrium. Moving on to structure number 3. Number 3, we look at the ventricle. So in the early embryonic heart, all there is a ventricle. This will be the strongest pumping chamber in the early heart, and eventually this structure evolves into the left ventricle of the human heart. And then we have number 4 and 4A here. So 4 and 4A. So these structures here, we have the bulbus cordus and the truncus arteriosus. And these structures will eventually evolve into the pulmonary trunk, the aorta, and the right ventricle. So that's what those structures will evolve into. So the big things to know here is be aware of these early embryonic structures. Okay? So be aware of these early embryonic structures. And what do these early embryonic structures of the embryo heart, what do they evolve into in the human heart? So make sure to be aware of that. What is the equivalencies here? All right, we move on. And the heart now has gone from the embryonic stage to fetal development. So the fetal heart is looking more and more like the human heart. So looking at circulation in the fetus. This circulation is going to be a little different from what we saw with the, it's a little different from the human heart. And there's different levels of oxygenation. So we look at what these early structures are. So first we'll go ahead and we'll take a look at the umbilical arteries. So the umbilical arteries, believe it or not, carry oxygen-poor blood from the fetus to the placenta. So umbilical arteries, and we can see that on the diagram here. Here they are. So very low oxygenation levels in the umbilical arteries. Ultimately, these are going back to the placenta. And then, of course, there's the gas exchange going on with mother. Another very important structure to be aware of here is the umbilical vein. The umbilical vein. And the umbilical vein is carrying oxygen-rich blood from placenta to fetus. So the umbilical vein is going to have a high amount of oxygenation. So a very high amount of oxygenation. So we now leave the placenta. Umbilical vein, this is the umbilical vein, I'm following up here, and a high amount of oxygenation in that umbilical vein. And eventually that hooks up with the inferior vena cava here. Other structures we find in the fetal heart is what's known as the ductus venosus And the ductus venosus here allows for blood to partially bypass the liver. Another structure to be aware of is the ductus arteriosus. So ductus arteriosus here. And this actually connects the pulmonary trunk and aorta. What this structure will eventually evolve into in the adult heart is a ligament known as the ligamentum arteriosum. And this is a ligament that you find kind of superficial up near the pulmonary trunk aorta vicinity. There's also in the fetal heart a structure known as the foramen ovale. So the foramen ovale. And the foramen ovale connects the two atria. So this is actually an opening where blood is moving back and forth really between. So the foramen ovale, again, you have blood going back and forth here from right to left atrium. Again, ductus arteriosus would be up in this vicinity right there. And what the foramen ovale develops into is the fossa ovalis. And this is actually a depression that we find in the right atrium. This is the remnant of not having the atrial septum wall between the right atrium and left atrium where blood is mixing. So those are some of the major things you find in the fetal heart, and just important to be aware of the function of these structures. And you can see the majority of these structures here are actually going to evolve into ligaments. The only one that doesn't is the foramen ovale, which becomes the fossa ovalis. But all the other structures actually become ligaments. We're now going to take a look at congenital heart defects. And there's a lot of different congenital heart defects out there. I'm just introducing you to a couple. Your textbook will go through many others that you can look at if you'd like. So, roughly, there are about 30,000 infants per year that are born in the United States with one or multiple congenital heart defects. And so ultimately, the parents really have to make a decision. Do we want to go ahead and go ahead and have the surgery? I mean, there's definitely risk factors involved, but if it's successful, definitely our child, the heart will be a lot healthier. So we'll take a look at these different defects. The first one we'll take a look at here, letter A, is the ventricular septal defect. And what happens here is the interventricular septum wall fails to form right here. So you literally have mixing of oxygen poor and oxygen-rich blood. The next congenital heart defect that we'll take a look at here is the coarctation of the aorta. And what this is referring to is the fact that the aorta is narrowed. So you can imagine the increased workload of the left ventricle. And we can see this up here in the diagram here, this narrowed aorta right here. So imagine the stress of the blood trying to go down the descending aorta here and carrying oxygen-rich blood. And the last congenital heart defect we'll take a look at today is the tetralogy of Fallot. So the tetralogy of Fallot. And tetra refers to 4. Okay? So tetra refers to 4. 4 congenital heart defects. So you imagine the stress that this child has. So the pulmonary trunk is too narrow. So imagine the stress of trying to get that oxygen-poor blood eventually to the lungs for gas exchange. So you can imagine that stress. So that's going to be right here. The right ventricle is experiencing hypertrophy. So the muscles are having a very hard time properly contracting, which is an issue. The individual will also have the ventricular septal defect. So the interventricular septum wall didn't form all the way. So mixing of oxygen poor and oxygen rich blood. And the last one here, number 4, the aorta opens from both ventricles. So imagine how difficult it is then to try to go ahead and get that oxygen-rich blood to the tissues of the body when some of that mixing there is oxygen-poor blood. So that gives you an idea again of just several examples of congenital heart defects that are out there. So I hope you enjoyed chapter 20, and we have one final review question here for you that is referring to the cardiac cycle. So, number 8 for review. During the cardiac cycle, the aortic semilunar valve and pulmonary semilunar valve close during which stage in the cardiac cycle? So based off of these choices, what do you think will be the correct answer here? So go ahead and take a moment to determine your answer. All right. So based off of these choices, the correct answer, the best answer here, I would probably go with choice letter D, early diastole isovolumetric relaxation. So here the ventricles are relaxing and the semilunar valves are closed. So it's certainly not going to be the ventricular ejection where the blood is going up, the valves obviously are open, or the ventricular systole. And ventricular filling is not the best answer here. Early diastole would be the best one here. All right, so hope you enjoyed this chapter, and definitely make sure to review those graphs. And your homework assignment will definitely help you here. So until next time, we are definitely going to be jamming.